Here we go, and we're live. Just me today. Welcome back, folks. My name is Paul Killoren. I'm the president, founder of iDryNeedle, physical therapist, dry needling PT myself. And I'm here today to kind of kick off our next season, I guess you could call it, of iDryNeedle to the point podcast. And really, next season means we are lining up another stellar list of industry leaders, of guests and panelists to have on our podcast starting in 2 weeks. So 2 weeks from today, we'll have our first guest. If you haven't watched the first couple episodes of iDryNeedle to the point, we talk dry needling, but we bring in other industry experts, other educators, researchers to talk specifically about dry needling in different contexts. So today it's just me. Again, my name is Paul Killoren. And really today I want to talk just 15 minutes. We try and keep these things pretty brief, to the point. Means we try and keep the discussion brief, 15 minutes or so. That's a challenge for me personally to keep things brief. But we have 15 minutes today just to talk about E-stim, specifically how we use E-stim with dry needling. First of all, this is probably the hottest topic on the product side, on the clinical and the education side. And just to give my personal history is when I first took, or when I was first trained in dry needling, when I took my first course in 2011, I'm not even sure there was a stim unit on the course. And then as we progressed 5 years, 10 years from there, now with E-stim being that much more popular, but even when we educate, we stim almost every needle we put in the body. And today we'll kind of talk about why, some of the rationale on the research side, but also why has E-stim become so popular or almost a preferred method of dry needling, indwelling electrical stimulation. And really, if I only have 15 minutes or less, first of all, start with the shameless plug. iDryNeedle, we created a 10 CEU, so a 10-hour E-stim course. It's fully online. It's built for clinicians that already know how to dry needle, are just looking how to more tactically use E-stim with dry needling. So today, if I have 15 minutes, I'm going to try and answer some of the most common questions when it comes to E-stim, but I'm really boiling down research and even some of the rationale and specific application from 10 hours down to 15 minutes. So that'll be a challenge. And if I go to 20 minutes, just drop off when you need to. So first of all, why is E-stim so popular? And the answer that you'll hear out there, and it's true, but it's kind of subjective, it's more empirical, is that it's more comfortable. Or at the very least, we'll talk about research in a second, at the very least, we can mitigate some of that post-treatment soreness from dry needling. We all know that there is a certain soreness expected after dry needling. For some patients or patient populations, that might be an issue. And you can talk about patient experience and clinical outcomes and all that, or you can put this in a very business-minded context. If you are nervous about patients or a patient population, as far as them, the follow-through or the fallout or dropping out of care because of the adverse event in their mind, which is excessive muscle soreness from dry needling. So meaning I'm saying if there are patients that you think are not going to be willing to try dry needling a second time or even come back to physical therapy because of some of the soreness with that initial dry needling session, E-stim is really one way that we've found you can mitigate some of that post-treatment soreness. And we do have research to confirm this, to substantiate that. Probably the best example is a 2016 publication. It's actually the Brazilian Journal of Physical Therapy. Author was Leon Hernandez. And what they did is group one, they went in and elicited 2 twitch responses from upper trap and then came out. That was it. Group 2, they went in and elicited 2 twitch responses, but then added 2 hertz, so low frequency stim for 15 minutes. And really what they found is both groups had improvement in lateral flexion, so side bending of the neck, Both groups improved in the NDI. The only differences between the two groups was what they said is the 0 and 24-hour pain rating. And again, their conclusion basically was the STIM group exhibited or complained of less post-treatment soreness than the other group. So if we're saying which is better, just dry needling, eliciting twitch responses, or eliciting twitch responses and perhaps using STIM, this research gave us, or I guess a platform that compared those two clinical scenarios. And the outcome basically was there's going to be less soreness in that 0 to 24-hour window after dry needling. Those authors did say that at 48 hours, the groups were the same. So I will say that this is not necessarily, from one bout of E-stim, this is not necessarily a long-term analgesic effect. This is a short-term or mitigating some of that short-term post-treatment soreness. So we do have research to suggest that. We have more research, a lot of it done on low back pain that compares just dry needling, just indwelling needles, and you really have to read the methodology as to how they use the needle. Did they just place the needle and leave it? Did they piston with that in and out maneuver, or did they use E-stim? And I'll show you a few slides in a second. But otherwise, as we go through this research, we have research that compares just dry needles to E-stim. We have a long list of case reports that use indwelling E-stim. And just to name a few, there's Rainey from 2013 on thoracic and low back pain. Fernandez de la Pena, in 2020, they actually used indwelling E-stim for a cubital tunnel syndrome that did not respond to traditional manual therapy, and they saw improvements. There was a 2019 JOSPT where they stim more specifically or closer to the radial nerve, so direct radial nerve stim using a needle, and that was for lateral elbow pain, and they saw improvement. There are a few meta-analyses and systematic reviews. The most recent one was Plaza Manzano. They just said that indwelling E-stim was effective for pain, that it was an effective treatment option. They didn't see the same outcomes when it came to function and disability scores, but their primary look, or I guess the research they gathered, did substantiate the use of dry needling and E-stim for pain modulation. So before we dive into the slides, if you're kind of on the pursuit of research yourself, it's probably worth discussing some of the different terms, like the names, the vernacular, and the terminology that you'll find indwelling E-stim under. Because I guess we're not at the point where you can just Google Scholar dry needling plus E-stim. That's starting to produce more publications. But what you'll find more of this research under, first of all, probably the most directly parallel term or application is called PENS. That's percutaneous electrical nerve stimulation. And even though it has the word nerve in there, PENS is really just stimulating an indwelling fine metal needle electrode. So that's very similar to how we use it in the clinic and education. So PENS, not to be confused with PNS, which stands for direct peripheral nerve stim. So again, that is either using a needle electrode, an indwelling needle, or a lot of it's used in rat and mouse research. They go in and put a surgical metal loop around a nerve, and then they directly stimulate a peripheral nerve. So obviously the motor response, the sensory, the nervous system response is much different if we're stimulating kind of the contractile components of a muscle versus directly stimming a nerve. So PENS and PNS sound very similar, but it's really a different target of our E-stim. Beyond that, does electro-acupuncture research count? The answer is it depends. I mean, just like anything with dry needling, I really think dry needling specifically, we have to be very diligent to read the methodology. So where are the needles? How deep are the needles? how was it positioned, how was it manipulated, and then what was the stim response. So just to paint different pictures, electro-acupuncture, where it is not to the depth of muscle, a muscular target, and the stim is not increased to the point of a motor response, that might not be as applicable to how we use needles, as if they go into detail saying the needle was placed 3 centimeters deep in the lumbar paraspinals, the E-stim generated a motor response, so a muscle pumping response. So that starts to look much more like how we do use needling. So we can't throw out all electroacupuncture research. I don't think we can include all electroacupuncture research. It's just kind of the call to diligence. That is, we have to make sure we know what the application is and really what the treatment intent was. Was it pain relief? Was it muscular changes? Was it anything else? And we'll talk more about that in a second. So that's worth knowing, because if you're out there trying to educate yourself, it can be frustrating to find these direct terms or these titles that fit exactly how we use it. And honestly, if we're just talking about the analgesic impact or what an electrically induced contraction is compared to a volitional contraction, we can use some research as far as the TENS and the NMES, all of our old school stim. If we're just trying to say what happens when a muscle is pumped electrically, as far as fluid dynamics or hemodynamics, like moving fluid, evacuating biochemicals, all of that, if we are just looking at that capillary and gaseous exchange of a muscle pumping, does NMES research count? I would say just for that very mechanical impact, we could. So some terms to search for if you're out there. But again, I'm trying to keep this brief. I already went much longer than I intended on the intro. I wanted to answer some of the questions that we commonly get on courses, but they even popped up on our Instagram questions yesterday. And honestly, most of them are around E-stim parameters. What's the ideal duration? How long should you E-stim? What's the difference between a low frequency E-stim versus a high frequency? These are probably the most common questions. Like if you buy into the fact, okay, I see this stim unit on a course or on social media, patients say they like it, clinicians seem really excited about it, so you buy it, or maybe you're out there looking for a stim unit to buy, but your immediate question is going to be, how high do I turn this thing up? How fast should I set the frequency? How long should I do it? So I'm going to try answering some of those questions. I'm going to share my screen here. And we'll start here. Again, I'm pulling directly out of, let's see if we can get this big. Pulling this directly out of our 10 CEU Clinical IQ Series course. Again, it's an online course made for dry needling clinicians wanting to learn more about E-stim. Honestly, it goes from the basics, like what are the units out there? How do we stim a needle? And then ultimately in the second half of the course, we get into how do we use E-stim for pain relief, for neuromuscular changes, for structural changes like combating atrophy, to athletic recovery, to neuroregeneration. Those are all the questions that we try and answer in this course. But again, to try answering some of the most common questions, and without just giving you my personal bias, because I do that enough anyways, I wanted to at least give you some breadcrumbs of research. So first of all, again, I was trained really without significant use of E-stim, and now I use E-stim on almost every needle I put in the body. So when people hear me talk about this, the common question is, so Paul, you talked about kind of these foundational theories, the trigger point model, the research and the significance of this twitch response, the spontaneous response from muscle. And now you're talking about E-stim. So which is better? So again, without giving my personal bias, this research group looked at just that. And Instagram, I'm sorry, you can't see the screen. Log on to YouTube after the fact. I think I'm sharing my screen here. So this research group had a cohort of chronic low back pain patients. Group 1, they put needles in L2 to L5 paraspinals plus the glutes. and they just stimmed at a low 4 hertz frequency for 30 minutes. Group 2 was also needling, but they didn't apply E-stim. They went in with that in and out pistoning maneuver. They did the deep paraspinals, QL, glute medius, logical muscles for treating low back pain. And once they looked at all the data of these two groups of chronic low back pain patients, they actually determined that they were equally effective. But when you get into some of the details, it's interesting because actually in their conclusion, they said that the dry needling alone was more cost effective, but the post-treatment soreness associated with the dry needling alone was higher, and that actually caused a higher rate of abandonment versus the indwelling E-stim. So again, this is kind of what I kicked it off with. You can paint a very clinical picture of, if I have these two options of using a needle, one is just pistoning some of our key targets, one is just using E-stim. If your goal is pain relief and you have any sensitivity to the patient experience or their comfort, or honestly on the business side, the fact that they're going to come back after that first session, E-stim, you can at least say, is as effective, and you won't have the same soreness, and you may even have a lower rate of abandonment. So if we're looking at those two, both are effective. Honestly, it's how you're trained, maybe when you were trained, as to whether you subscribe fully or not at all to the use of E-stim with needling. But at this point, we're finding that it performs at the same level as just pistoning, but there are certain benefits. And here, one of the benefits is lower rate of abandonment. Because I'd even say in the conclusion here, when they say that dry needling alone is more cost effective, they base that off of the fact that that group had fewer visits overall. But they also admitted that that group also had higher dropout. So really lower visits, but higher dropout. That may not be cost effectiveness. That might be dropout from your research study. So I'd say they're the same. There are certain benefits. Here we look at, again, can't see the screen on IG, but this research publication looked at a similar group of low back pain patients. And the question they're trying to answer here is, what frequency is best? Or does it matter, I guess? So again, these are patients with chronic low back pain. If you're looking at the slide, you see they did the L2 to S1 paraspinals plus the glutes. Again, that's a pretty classic low back pain circuit to set up. And here they have 4 groups. All of the groups get needles in. The first group is sham E-stim. The machine's not on, so it's just indwelling needles, no E-stim at all. Group 2 is a fixed 4 hertz, so a fixed low frequency E-stim. Group 3 actually alternated between 15 and 30 hertz. So it went back and forth from 15 hertz, then 30 hertz, then back to 15, then back to 30. It was alternating every 2 or 3 seconds. And group 4, they did fixed high frequency, 100 hertz, which if you've never seen or experienced that, we kind of know that a muscle's cramp threshold or tetany is achieved 17 plus or minus 5 hertz. So we're saying 12 to 22 hertz, somewhere in there, a muscle will no longer be just like a thumping, a segregated contraction. It'll be a cramp-like tetanic response. So we have sham, fixed low hertz, alternating in between, and fixed high frequency. What they said is that all of the groups that received any type of E-stim outperformed the sham. So E-stim did help decrease back pain compared to just statically placed indwelling needles. They also found that as far as the pain scores, physical activity, and actually quality of sleep scores, that 15 to 30 hertz group was the best, statistically significantly the best. So really they would, again, the conclusion as they write it is that 15, 30 hertz is the preferred method, or it performed the best for low back pain patients. You can look at that 2 ways in my mind, and this is me infusing my own or extrapolating from this research, but you could say very specifically that there's this magical zone of 15 to 30 hertz that's just the best frequency for pain relief. Or I would actually challenge that that was the only E-stim group that received an alternating stimulus. It didn't stay at a fixed low, it didn't stay at a fixed high, it was moving back and forth. So to me, when people ask, Paul, what's the best frequency for pain modulation? My recommendation is actually move around. Like there are stim units like the 6-channel stim unit, the ITO ES160, that you have settings where it's either alternating back and forth, or it can sweep up or sweep down in frequency. So there are stim units that do that automatically. Otherwise, if you're using the Pointer Excel or the E-stim 2 or the 3-channel stim unit, I would just say if your goal is to stim for 5 minutes, 10 minutes, 15 minutes, don't stay at a fixed frequency. Spend a minute or two here, a minute or two here. But to me, it's the alternating frequency stimulus that has the most profound impact when it comes to pain modulation. But again, the findings here was that 15 to 30 hertz was better than any other group. Stim was better than no stim, 15 to 30 did better than the others. So the same group did a follow-up study, and here we're looking to answer the other common question, which is, okay, I buy into E-stim, sounds like I should be changing the frequency, or maybe I'll do this 15-30, I'll just follow research. So how long should we do it? What's the ideal duration? And again, this is chronic low back pain. The goal here is pain modulation, because in a second, we're going to talk about what if the goal of E-stim isn't pain relief? What if it's fill in the blank? But here it's low back pain. They're trying to see which duration is best for pain relief. And again, if you can see the slide here, Instagram, stick with me. Every group received that alternating 15 and 30 frequency. Again, it's a follow-up study. So they basically said, all right, in our first research, we found this perfect frequency setting. So now every single group is going to get that same frequency setting. It's the exact same needle setup. Again, L2 to S1 with the glutes, chronic low back pain. So now the 4 groups are, again, 0 minutes. That's sham. Needles are in, but there's no E-stim applied. Group 2 is 15 minutes, group 3 is 30 minutes, and group 4 is 45 minutes. So again, same circuit, same E-stim frequency. What is the impact of duration? And again, if you can see the screen, you see our data as far as pain relief, physical activity, and quality of sleep. And unfortunately, this is kind of one of those findings where the research findings, the research results don't always paint like the most clinically realistic picture, because what they found is that the 30 and 45 minute duration was substantially more effective than 15 minutes or the sham. So they tried adding a little bit of reality and said, if 30 and 45 are by far the best, but there's not much difference between 30 and 45 minutes, the recommendation is 30 minutes. So based on these 2 breadcrumbs of research, if you're looking for pain relief, specifically they're looking at low back pain, it is an alternating frequency, or again, they said 15-30 hertz, and it's 30-minute duration. But again, to add the clinical reality, or just to give a more broad strokes recommendation, I would say alternate the frequency, don't stay in the same spot. And then if pain relief, if analgesic effect is our #1 goal, let's just say that longer duration shows a better effect. So maybe we don't have time for 30 minutes in that treatment session, but let's say 30 is better than 20, maybe 20 is better than 10, maybe 10 is better than 5. But again, this is kind of one of those disconnects, the mismatch, where research doesn't tell us exactly what we want to hear, which is you stim for a minute and everyone feels better. So there does seem to be a certain impact duration has on pain relief. And when we read stuff like this, I mean, I think there are very specific patient scenarios where we directly apply what we see in research. Meaning, picture that patient, that acute low back pain, that acute disc. They just injured themselves this morning. They scheduled during your lunch hour because that was the only opening. They don't even sit down in the waiting room because their low back pain is so high. It's so irritable, 9 or 10 out of 10, like true 9 or 10 out of 10 pain. They have a lateral shift. They don't want to walk. They don't want to move. They don't want to lay down. So picturing that patient, maybe it would be my explanation to say, Bob, when you've come in the past, the emphasis has been on movement and exercises, and I sent you home with like 5 things to do for homework. But today, I have one goal today with my treatment, and we're going to start with the needles and E-stim. But my one goal is to decrease your pain. Like if we can even bring that 9 or 10 out of 10 pain down to a 6 for now, for the next 24 hours, so that you can just walk around a little more, sleep a little better. That is my number one goal. So in that very specific scenario, maybe it is worth 30 minutes of E-stim for back pain if that performs the best. And our number one goal for that treatment session is pain relief. Maybe we just go for the longer duration. And then they come back tomorrow, and then whether the pain is, whether you maintain that effect or not, you can start to focus on less of the pain focused treatment and more of restoring function and mobility. But duration seems to have an impact. This is actually the same research. A very exciting secondary finding was that 30 and 45 minute E-stim duration group for low back pain showed a statistically significant reduction in their daily oral analgesic intake. So that's less pain medication. And if we want to take this into the big context of the opioid epidemic and everything else that we are in right now, as far as non-pharmaceutical, non-surgical pain relief options, this gives us a nice picture, paints a graph. The data supports the idea that needling and E-stim should at least be an option to consider for pain relief or to reduce daily pain medication intake. So again, those are just a few breadcrumbs, I guess not to tease you, but to answer some of the questions. What's the best frequency? What's the best duration? And again, I'm painting very specific patient scenarios because what if our goal isn't pain relief? And man, I'm way over time. If you need to drop off, if your patient is in the waiting room, you got to go. But I'll be back here on YouTube and I'm going to finish up quick. What if your goal is not pain relief? And again, we go into all the research and the data in our clinical IQ course. But what if your goal isn't to decrease pain, but it's to improve muscle function? And really, when you talk about neuromuscular changes, are you trying to improve recruitment, like contractile thickness on ultrasound, or EMG latency, like just how a muscle recruits? And then we're going to reinforce it with exercise. Or are we trying to have physiologic or metabolic or ultrastructural changes to the muscle? Meaning, are we trying to combat atrophy? Are we literally trying to build a bigger, stronger muscle? If that's true, if that is your goal, it's not pain relief, it's muscular changes, then our E-stim application looks very different. And not to give away all of our answers, but we don't do a low frequency, long duration. We actually do the opposite. We do high frequency, so 20 hertz or more. Again, we're above that cramp threshold. We're generating a tetanic response, but we only do short burst durations, 2 or 3 seconds on and then off. So if we want muscular changes, high frequency taps into a different potentiation. Our largest diameter motor axons have the lowest electrical threshold, which means we can literally generate an electrically induced contraction that they may not be eliciting volitionally. We can tap into recruitment patterns that are opposite of our temporal summation. We also have data that if we combine this high frequency, this burst E-stim with sport-specific functional training, so this is basketball players doing jump training, this is soccer players doing plyometrics, that if you're adding E-stim to that training, there are improvements over long periods of time. So preseason, full season, that sort of thing. One more scenario, if your goal is not pain relief, and now your goal is not muscle function or muscle performance, What if your goal is to use dry needling and E-stim just for the sake of athletic recovery? Whether you're seeing a pro athlete, an endurance athlete, a high school athlete, our goal isn't to improve how they move or decrease pain or soreness. It's just to stimulate a recovery effect. So there again, we're not doing an alternating frequency. We're not doing high frequency burst duration. If our goal is athletic recovery, most of the research guides us to the point of we just want to generate a low frequency muscle pumping action. So low frequency, 2 to 4 hertz. Just think of that heartbeat thump. And maybe we're choosing muscles that are large, that have the ability to move fluid. It's called O2 flux capacity, which sounds like something from Back to the Future, but really it just means based on the size of a muscle, based on the capillary density, certain muscles have the ability to soak up, but also move fluid, move blood, move metabolites and biochemicals. Certain muscles do that better. And if you want very specific examples, a large muscle, lower extremity, we have our glute max, we have vastus lateralis. We know as far as venous return and lymphatic return or lymphatic activation, gastroc, aside from all of the things that gastroc does, as far as proprioception, knee flexion, plantar flexion, all of that, it's the classic example. Gastroc is built to be a vascular or a venous engine, literally pumping through the valvular system of our veins, pumping blood back uphill. So that's really the idea if you're using E-stim for recovery. Large muscles, low frequency, probably longer duration. And if you're trying to paint the whole clinical picture, I think we're going to do less pistoning. We're trying to disrupt tissue less if our goal is recovery, meaning we're not trying to prompt an acute inflammatory response as much. We're really just getting muscles to pump. So really it's hopping from topic to topic, but I'm trying to paint this picture of the way we use E-stim with needling shouldn't look the same for every patient. Or even with that patient, it shouldn't look the same for every phase of rehab. Think of an acute or a subacute injury, a hamstring strain or an ankle sprain. If we're in the acute subacute phase versus the remodeling phase, functional phase, or return to sport phase, we shouldn't be using our needles and E-stim exactly the same every single visit. So hopefully some of that research or some of this conversation opens up the context of what we're trying to do or where research is really going with dry needling and E-stim. Way over time, so I won't go much longer, but there are different units out there that make this easier, that have more capabilities and more versatility with our E-stim. Otherwise, there are some great starter units. If you're just saying, give me a starter unit, bang for your buck, what's the best one out there? I would say the E-stim 2. It's one of the most affordable. It's one of the most durable. It's 2 channels, so you can get a lot done with 2 channels, which is 4 clips. So if you're just looking for somewhere to start, the Pointer Excel is really the best beginner unit because it's a handheld that forces you to be very precise, very specific. You're stimming 1 or 2 needles at a time. Otherwise, the E-stim 2. And there's a lot more. I'm actually seeing them come in, and I'm sorry if I'm missing them on Instagram. You're sideways up there. I know this is going to generate more questions. And again, if you don't have the time to take the full course, I think we'll do a follow-up of this type on our podcast as far as answering not just big picture questions of E-stim and dry needling, but really more specific. We can go deeper into recovery. We can go deeper into combating atrophy. We didn't even talk about how to E-stim for neural regeneration. Otherwise, there's specialty populations like neuro using E-stim for spasticity. So this is a big topic. I went way over time. And just reading the question in the window. E-stim for nerve laceration injuries below the site of injury. So yeah, that's from Alex here. Yes, that is how most of the research is done actually, is on human subjects. They have true nerve laceration injuries or very severe, like to the point of atrophy as far as carpal tunnel, cubital tunnel, that sort of thing. And that research is directly stimulating that peripheral nerve. A lot of the rat research, they go in and completely sever the sciatic nerve. And then group 1 mice, they see how once it's sutured back together, how it heals normally. And in that other group, they suture like that ring, that loop metal electrode that they can directly stimulate a nerve, and they see how quickly that nerve regenerates. And that's a big topic because if we're directly stimulating a nerve, we do have the potential to injure or degenerate if we're too aggressive mechanically with our needle or too aggressive with our E-stim application. Nerves don't like high frequency. So just if you want to stay safe with nerves, typically we're very low, like 2 hertz. But the answer is yes. And since we're going kind of down the nerve injury route, we actually have data that says we don't need to get our little monofilament metal needle directly into the epineurium or even directly against the epineurium to get a direct peripheral nerve stim to have benefit. It's called the blood-nerve interaction. But basically what that means is if we can treat with our needles and with E-stim, if we can treat muscular targets that are above, below, adjacent, or surrounding a nerve, if we get a muscle pumping action to those perineural contractile targets, we can engorge that vasa nivorum with blood. If we get muscles to pump around a nerve, that's one of the best ways to pump blood and nutrients into a nerve. So we know nerves need blood and they need space, and then they need to be used. So that we need something that activates the nerve. So an intraneural, we're talking exoplasmic flow and action potentiation, but then we need blood flow and nutrition. And then if there's any specific osteofibrous or myofascial tethering sites that are affecting the neuromobility, that's how we treat nerves. But thanks, Alex. That could be a completely separate podcast, and maybe it will be. But yes, we can use it for nerve laceration or neural regeneration. It just might look a little different as far as where we place the needles and the frequency we use. Like there was data that when you use 20 hertz high frequency near a nerve, that actually decreased the health and function of the nerve. So we can denervate with high frequency. I missed some questions up on Instagram, but again, I'm sideways up there. So I promise to post answers to the questions that are up there. But again, this was meant to be 15 to 20 minutes. I'm way over time. So I'm going to wrap this up. Again, my name is Paul Killoren. This is iDryNeedle To The Point podcast. If you missed us live, it'll be on YouTube. It'll be on our Podia platform, iTunes, Spotify, all of your podcast sites. And I'm really doing this to kick off our new season, I guess you could call it, but our 2021 schedule of panelists, which will start in 2 weeks. And we have some great industry leaders. Honestly, not all of the panelists that we're inviting on this season endorse dry needling. So we're going to get into some of those, like agree to disagree, or, being as professional as possible. We're not going to have aggressive debates, but we're going to introduce people that aren't necessarily just researching or readily using dry needling. And honestly, some of them having skeptical stance to dry needling. So we're going to expose you to everything. 2021 will prove to be an awesome schedule. But even in our first 10 episodes in late 2020, first of all, we had rock star guests, but our audience significantly increased. So thank you for following. If you don't follow us on social media, myself, Paul, or Shannon works for us as well. She's a dry needling clinician. We run our social media, so at iDryNeedle, Instagram, and Facebook. Otherwise, we are building out our YouTube channel, so look us up. Thanks for listening. I will answer as many questions as I can that I missed, and we'll see you in a few weeks.